Good evening, everyone. Thank you for attending the Working in the World of Diabetes webinar hosted by Diabetes Hope Foundation. Tonight's webinar will focus on professionals in the medical and healthcare sector, and there will be a discussion about working in diabetes care, and we're focusing on the intersection of diabetes and mental health. For those of you who don't know me, my name is Rav, and I'm a program facilitator with DHF. I've had type 1 since I was 2, so it's been a very long time since I've lived with it, and it's a pleasure to be one of your co-hosts this evening.
Thanks, Rav. My name's Heather, and I will be the other co-host for this evening. I'm also a program facilitator with DHF, and I've had T1D since I was 12 years old. I'm a teacher candidate in the Trent University Bachelor of Education, and I'm so excited to be here with you tonight.
Thanks, Heather. So a little bit about Diabetes Hope Foundation, or DHF. We are a Canadian not-for-profit organization founded by Barbara Pasternak in 1999 after two of her sons were diagnosed with diabetes. DHF supports youth living with diabetes as they transition from high school to post-secondary life and beyond, offering resources, education, and programs designed with healthcare professionals and folks with lived experiences across Canada. DHF's work focuses on helping youth maintain effective diabetes management during this critical period, while also addressing the ongoing mental health challenges of living with type 1, and to empower young people to thrive in all areas of their life beyond their condition. And we also work closely with diabetes clubs at universities to help educate students who want to pursue a career in medicine to kind of debunk some of the misconceptions around living with type 1 in hopes that they carry this messaging into their careers.
Now let's meet our speakers. We're going to introduce them, and then they will say a few words. Let's start with Dr. Vallis. Dr. Vallis is a health psychologist based in Halifax, Canada. He is also an associate professor in family medicine at Dalhousie University. His main area of expertise is adult health psychology, with an emphasis on obesity, diabetes, cardiovascular risk, and gastroenterology. He spends much of his time training healthcare providers in behavior change for chronic disease management, supervising students, and conducting research on motivation, behavioral change, and adaptation to chronic disease. He has been heavily involved in academic publications and clinical practice guidelines, including serving as an executive on the 2020 Canadian Clinical Practice Guidelines for the Management of Obesity. He is also an author of the Psychology and Mental Health chapter of Diabetes Canada's Clinical Practice Guidelines and has received multiple national awards for his contribution, including the 2021 Charles H. Best Award from Diabetes Canada, and holds a Queen's Diamond Jubilee Medal by the Government of Canada. Thanks for being here, Dr. Vallis.
Hi, everyone. My name is Michael. I have the privilege of working in a medical field from a psychological lens. And this, I think, has been a really incredibly valuable experience. So as a psychologist working in diabetes, I really hope that we can talk about how when you really integrate the medical and the psychological, you'll get much, much better outcomes. And if you put yourself not in the lead, but as a collaborator, as a partner, and importantly, as clinicians, we're really told to are taught rather to make recommendations, to make education. In other words, it's so easy for healthcare professionals to be telling people what to do, to take the lead. And so diabetes represents a disease where when you do that, it doesn't go well. And so we know that we really need to revise our approach to diabetes in which we listen first before we speak. We understand the individual and what's important to them before we make recommendations. And that's sort of an area that I represent. So I'm really happy to be here today to just to really help you kind of see just how functional diabetes management services can be for the professional. So I really love being a diabetes psychologist because I work hand in glove with my medical colleagues and hopefully the people that we have the opportunity to spend some time with will benefit from that integrated approach. So thank you for allowing me to be here.
Thank you, Dr. Vallis. Next up, we have Alana Landry, who is a diabetes educator with over 30 years of experience dedicated to advancing diabetes care and equitable access to technology while improving outcomes for people living with diabetes. Throughout her career, she has worked across clinical practice, system leadership, and research to enhance transitional care from pediatric to adult programs. She's an active member of ISPAD, contributing to international guidelines and benchmarking strategies. She currently sits as co-chair of the Provincial Diabetes Network, where she collaborates with clinicians, policymakers, and patient partners to strengthen diabetes care delivery and promote system-wide improvements across the 35 provincial programs. Welcome, Alana.
Thanks so much, Rav. It's great to be here. Looking forward to the conversations this evening. I, like Michael, really like these opportunities to talk about how mental health and clinical care intersect and how we can best support people as they are living and thriving with type 1 diabetes, and know that although there is some clinical responsibilities, that it's our job to walk alongside of the families and our patients and help support and establish relationships as probably the most important part of our work.
Thanks, Alana. Kirsten Davidson is a registered psychotherapist and the founder of the Mind the Gap Psychotherapy, a practice dedicated to providing support for life, lifelong support for life's concerns. Her approach empowers individuals to step out of their comfort zones and into their growth zones, cultivating meaningful personal transformation. Having lived with type 1 diabetes since the age of 6, Kirsten brings both clinical expertise and lived experience to her work with individuals navigating T1D. She offers services to adults through individual therapy, couples therapy, and family therapy, remotely across Ontario and in person in Burlington.
Hi, Heather. Thank you so much. And hi, everyone. So grateful to be here. Just building on what Dr. Vallis and Alana have shared so far. I believe there's no separateness between mind and body, so I think it's a pretty beautiful experience to help my clients observe how the mind influences the body influences the mind, especially as type 1 diabetics. And, sitting in the seat as a type 1 diabetic, there's that extra bond and extra level of care there with my clients. So I'm hoping that tonight everyone gets to learn more about the nuances of living with type 1 and get more of a holistic understanding of what patient-centered care looks like, and also tapping into this humility that even as the experts, we have to treat the clients as the experts of their own lives.
That was wonderfully well put, Kirsten. Thank you so much. And now we have Ethan Parikh, who completed his undergraduate degree at McMaster University, and he is now a second-year medical student at the University of Toronto. Through advocacy, mentorship, and research, he is passionate about connecting with others within the diabetes community and learning from their lived experiences. Within the DHF community, he enjoys serving as a mentor with the Hope Connects Peer Support Program, emceeing the annual DHF scholarship ceremonies, and contributing to resources like the Guide to Adult Care. He is excited to be a panelist to discuss the importance of mental health within diabetes care and to learn from others pursuing careers in medicine. Welcome, Ethan.
Thanks so much, Rav. Rav and Heather, it's really great to see you both. And thanks for having me on this panel. As Rav said, my name is Ethan, and I'm currently a second-year medical student at the University of Toronto. I'm really excited to be here today. I think some of the topics that we're going to talk about today are very, very important, and I know I'm really excited to learn from the rest of the panelists and from all of you. Just a little bit about me. I have kind of the dual identity of also being a patient. So I was diagnosed with diabetes about 10 years ago when I was 12. And I really enjoy events like this where I can connect with other people and learn from other people within the realm of diabetes. And I'm really excited for the conversations we're going to have today. So thanks again for having me.
Thanks, Ethan. So now we're going to jump into our questions. So the first one we have is, for students who want to work in diabetes care, what responsibility do they have to learn beyond the textbook, especially from people with type 1 diabetes? And how can they do that?
So, Rav, I know that if anybody specifically wants to get into nursing to be a certified diabetes educator, they need to have 800 hours of experience with direct teaching. And if that's an avenue they want to pursue, they can start to get that once they graduate from their degree program by working or volunteering at diabetes camps, working on units where there is diabetes education being taught, whether it be in an intensive care unit, on a general unit. There are opportunities to get some of that direct diabetes teaching in order to be able to write the exam to pursue a career in diabetes education, in nursing.
Thanks so much, Alana. Our second question focuses on how can clinicians better recognize that a person with type 1 diabetes is the expert in their own lived experience, even when the physician is the medical expert?
Perhaps I can take this one if that's okay. This is an area that I spend really most of my time trying to sort of work between, which is, who's in charge. And the reality is, really, even up until this day, most of us as healthcare professionals are trained to be the experts. And what that means is that we sort of think our job is to make the diagnosis, in other words, tell the person what their problems are, tell them what the treatments are. So we're going to tell them what to do, and then we measure their outcomes and then tell them how they're doing. And in some disease states, this works perfectly fine. Here's your problem. Here's your solution. Go do it, and we'll see how you make out. In diabetes, this ends up often in a disaster because the person living with diabetes knows their disease. They know that they are expert in their own condition, and they can only benefit from recommendations when they fit who the person is. So we have this somewhat tension between clinicians and people with diabetes or any other chronic disease in terms of who's in charge. And so our colleagues, for instance, it's common if you look at the experience of the relationship in diabetes, it's very common for people to make comments like, I kind of feel like I'm being called into the principal's office when I go into the diabetes center. I'm nervous about seeing the endocrinologist. I worry that my diabetes educator is going to be upset with me. And so you think about this, where does that come from? And because it's not the clinician's intention to come across as disciplinarian, and yet this can sometimes happen. So as you're thinking about this at your stage of your life, when you're thinking of going into the field of diabetes, I think it's the perfect opportunity for us to really kind of start afresh with this disease, to really start with the person's lived experience as equal expert to the person, so that the medical expertise is really just options. And if you don't do that, if you don't establish the relationship which is equal. And that's actually difficult. And it's difficult for the patient. It's difficult for the person because they're vulnerable. So if you're struggling with your diabetes and you're going in to see your endocrinologist or you're going to your diabetes center, you're going to kind of go feeling like, oh, you know what? I really hope they can help me. I really value the time they have. So you're kind of a little bit in a sort of a subservient position. And then as clinicians, we want to do the best for you, and we have limited time, and we've seen it work on other people. So it's super easy for us to say, nice to see you. How you doing? Let me tell you what you need to do next. And so I think one of the things that we need to really think a bit about, and this is what's so exciting about the field of diabetes, where the psychological, the mental health part, and the medical part are really being put together. So for instance, the European Association for the Study of Diabetes, EASD, has a group that's now going to become a much more prominent group inside of this European organization called the Psychosocial Aspects of Diabetes. They've just published guidelines that have been accepted by the Europeans, and now we're really looking at how to bring in the psychological signal. And so this, I think, is really, really important. So as you're thinking about this, I think it's so important for us to really recognize that, we understand it as clinicians. But because we're helpers, because we're busy, and because we've seen it work in the past, it's so easy to fall into what I call teach and tell. And so the challenge is we have to view people with diabetes as vulnerable. And what that means is that we as health professionals have to really have that humility side baked in. And one of the things that I would suggest, many of the people who would be in this conversation would live with diabetes. And I really want to try to suggest that we need to feel entitled to communicate our needs. So they're not secondary, they must be primary. And what happens when the relationship between a diabetes provider and a person with diabetes goes wrong, it can be made right if the person with diabetes it has a voice. Because one of the things that you will always see with chronic disease is when patients tell the clinicians what the problems are, the clinicians will not ignore the problem. But if the clinician kind of takes charge, it's very common for people to become silent. And in fact, in primary care, this is sometimes called the hand on the doorknob phenomenon. In other words, you go see your family physician, and then you're about to leave the office. You put your hand on the door to go, and you say, "Oh, by the way, doctor." And it's kind of like that's why you came into the visit, but yet you didn't have a voice until you're just about ready to leave. How does that happen? Because of these sort of natural power dynamics. So I think as we think about the next generation of diabetes providers, given the work that we've done to recognize the importance of integrating mental health and physical health, I think now is the time for clinicians to have a common training that allows us to really appreciate and be able to act on the fact that the person with diabetes is the expert. And our job is really just to provide the information to support the person in their decisions and to help them in the journey that is there, that they are motivated to manage. And I'll stop there.
Yeah, go ahead, Elena.
Yeah, I wanted to add one more thing, kind of piggybacking on that. But in a lot of the research that I'm involved in right now, each time we have a research grant that we're writing, we look for people with diabetes to be part of the initial grant so that they're part of asking the questions, and the research is designed around their feedback and their questions and some of the things that they would like to see the outcomes look at. And that has been in the last 5 years of my career, most recently with the research that we're partnering with other programs and doing. A lot of involvement is coming from youth with type 1 diabetes at the very beginning of the research questions. So that's another really good way to get involved early. And there's quite often opportunities. Ex-patients of mine have been involved in writing a lot of the articles and being part of the grant writing. So that's another opportunity to get involved earlier to help kind of pave the way for a career for somebody with type 1 diabetes in the world of working in type 1 diabetes.
Just to jump in as well off of both of those things you shared, Alana and Michael, I think that's really exciting, the developments that are happening in terms of teaching and looking at it at a systems level and changing the way we're educating clinicians to look at things more holistically. In my work, we're taught stay curious, always be inviting the client into the space to share their experience. And that also helps us check in on ourselves and see, like, are we putting ourselves in the seat of power right now, or are we allowing them to be in the hot seat? So yeah, the doorknob confession, that's definitely a thing, especially in the therapeutic world. So it's when they actually settle into the room, asking them, okay, so how are you really? Like what's really going on here? Especially in my work, for anyone looking to become a therapist, working in the mental health sphere, I think depending on your level of comfortability with the client, it can also be okay to ask, how's your blood sugar been today? Because if someone's coming in and they're high or they were just low and maybe they need a minute to kind of recalibrate literally before we go and do some deeper diving, instead of just treating everyone as kind of like coming in and out and revolving door, really getting into their individual experiences in those moments. I mean, the only commonality amongst type 1 diabetes is our pancreas doesn't work, but the lived experience of the faulty organ is completely unique.
And I think you're absolutely correct. The curiosity is absolutely essential, especially if you pair it with being non-judgmental. So for me, as a professional interacting with diabetes, non-judgmental curiosity, I think, is really the key to establishing a pathway that is going to make sense to the person as well as to the disease itself. So it's actually a really great phrase to be thinking about. Always be curious.
Ethan, I was wondering if you had maybe anything else to kind of add to that as someone who is living with diabetes yourself, and then also as you're kind of pursuing this career in medicine, what is kind of your take on this question?
As someone who has like the dual identity of being a patient and also a medical learner, one thing like I've realized is that we can't really fault like endocrinologists and other healthcare professionals for kind of being experts because they have learned a lot of the objective elements of diabetes management, like how to read graphs, like how to understand how someone objectively is doing. We can't fault them for not fully understanding like the patient perspective because ultimately that is very hard to teach someone in medical curriculum. I think like there are many people here who are much more professional than me who would probably say that interacting with patients over a long time can give you a lot of experience to be able to have that introspection when talking with patients. So I think part of it is giving your physician a bit of grace, and sometimes it's not their intention to not be fully aware of what's going on in the patient's life. But again, as been said, just previously being able to give patients the space to be able to explain that in a way that doesn't seem rushed, in a way that doesn't really seem like an afterthought. I think all those are very important strategies that you can kind of incorporate. And as a patient myself, I know I appreciate it when, people create the space that I feel like I'm not being, rushed out of the room, or I have the chance to explore like things kind of beneath the surface rather than just to, for example, talk about my numbers.
Thank you. Now, this kind of like perfectly segues into our next question that people living with type 1 are making their own dosing decisions every day, which is something I didn't realize I had the power to do until I was maybe in my early 20s, which was like 18 years into my diagnosis. So, how do you support patients in building that confidence around that responsibility? And in turn, how can medical professionals address some of that guilt, shame, or perfectionism that kind of shows up in diabetes care without reinforcing it?
Yeah, so I think it's a very delicate dance because I think type 1 diabetes is something especially that there's a lot of trial and error for on behalf of the endocrinologist and the care team, but also the patient. And there's many decisions that have to go probably minute to minute for patients when living with diabetes, like considering many, many different factors that affect blood sugar. And so just to, I guess, firstly, I think, part of the patient's, I think, responsibility to share with the endocrinologist a little bit more about their life. And I think when you try to use a one size fits all approach in management, it often doesn't work. And I think that's something that's been brought up before. So I think part of the patient's job is to just, other than just being a name, to kind of bring their story and where diabetes fits into their life to their doctor's office, because often that really helps the endocrinologist and the rest of the care team put their management strategies in the context of their life, which I guess has the highest likelihood of being like adhered to, and personable enough for someone to feel like they're actually being empowered, rather than just being given like a very general management strategy. And so I think like guilt, shame, and perfectionism, as going back to the question, are very, very common. But in kind of thinking about my experiences and also like talking with a lot of young adults who also live with diabetes who feel this way, it's very hard to not feel this way. I think diabetes is a very interesting chronic condition where a lot of the emphasis and guidelines and management strategies are all targeted towards numbers. But as patients and also within the field of diabetes, we often try to stay away from just focusing on the numbers. So, it's putting all of that into context and especially making things patient-centered that I think can help with some of those feelings.
I might pick up there. I think, Ethan, you've said something that's super, super valuable, which is to really, the voice of the person has to come out as soon as possible, because the reality is people with type 1 diabetes make most of the decisions. They always have, and they always will. Diabetes shows up in almost on a minute-to-minute basis, and there are so many variabilities that it's almost impossible to have a standard approach. So when Ethan describes, kind of maybe being the first voice in the conversation, then what that will do is that'll set the tone. If you don't have that first voice, Ethan, then what will the doctor do? What will the clinician do? Well, they'll think about clinical practice guidelines. They'll think about randomized controlled trials. They'll be thinking about numbers. And then the problem with that is that the problem of averages is that nobody is average. And so here you've got this body of science that says, in this situation, do this, and this is the outcome. But if that's what we're recommending, because that's what the evidence shows, then that's what we say. But then it doesn't take into consideration the fact that that's not how it shows up on a day-to-day basis. So that voice of the person, I think, is so important. We know, I think it's generally known in the public that the last thing you do if you're raising children is with a school child, a child in grade 6, grade 7, grade 8, to say, what do you mean you got 92? What happened to those other 8 marks? We know you would never raise a child like that. You reinforce the child for what they do. In diabetes, what do we have a tendency to do? Clinical practice guidelines say you should be below 7. You're above 7. What's wrong? So you can see how we make this fundamental error that we kind of know isn't a good strategy to do. How can we be so silly to fall into that pattern? And it's kind of an occupational hazard. And that's why when you talk about putting the person's voice first, Ethan, then that's what sort of anchors it. And then then the clinician is only going to be able to say anything relative to what the person has said. And that is what allows that. Second point I'd like to make about, the decisions and being made and the shame and the guilt is I think we need to start to reinforce people for what they do. When it comes to disease, there's a tendency to think about it from the perspective of you're abnormal and we got to make you normal. Well, when you think about it, the only problem that you have when you have type 1 diabetes is your pancreas has failed. Other than that, there's absolutely nothing wrong with you. And so that model doesn't really work. And so I think what we need to do is reinforce people and start to help people. So even as young as, in some families, it may be children as young as 7, 8 years old. We can begin to get them involved in the decision-making process. They can have all kinds of time to get comfortable with those decision-making. And it's a two-way street. You could take on decisions, and if they're not working out, you can say, okay, maybe I should pass it back and let my doctor be a bit more involved, or let my diabetes educator be more involved in this decision. So it's not an all or nothing. It's a very fluid movement. But I think you're absolutely right that we need to think about this in the sense of respecting it. And one of the things that I think we've learned tremendously, this is probably a message that I think is really worth hearing, and that is the sort of automated insulin delivery systems. We would not have automated insulin delivery systems if it wasn't for people with type 1 diabetes saying, we are not waiting. And there was a hashtag, we are not waiting initiative that started. People living with type 1 diabetes, they got using their own resources. They hijacked the system and they programmed CGMs and pumps to talk to each other. And they shamed and embarrassed the professional community because we were thinking there, we're going to wait and make sure it's safe and we got to test it. And those research projects were kind of, in the works, but they probably would have taken 5 or 10 years. We are not waiting. They did their own hybrid systems. They made them work. They put them on the internet. People were using them. And then the professions caught up. So when I like that story because that story really shows that we're equal experts. And by supporting the competencies and the confidence of people with type 1 diabetes. And so that's the thing. What I like about being a psychologist is that it's just not a sickness model. It's just not you have a problem, we need to make it go away. It's how do we make you thrive? So positive psychology, and how do we really empower people and help people to take the actions that they are available to them and use those actions to build their own confidence. And as a psychologist, I very, very strongly believe that everybody is on a personal journey, but we can all have a journey that's associated with empowerment and with confidence. And I think with diabetes, we actually have an opportunity to support that as early as possible.
One of the things I think clinicians are responsible or could do a better job of is helping clients, when they come in, reframe maybe a negative way of looking at or thinking about different aspects of their diabetes. If they were diagnosed really young, maybe the language that they were taught many years ago or that parents maybe passed on, but really, really putting more of a positive spin on all the hard work that they're doing and reframing how they're the lens that they're looking at all the great work that they're doing and the diabetes management and how how positive it actually is. And also, when a lot of our patients now on AID are coming to clinic and giving our patients, the people with type 1 diabetes, permission to not have anything changed at clinic appointments. Sometimes government regulations stipulate they have to come in as frequently as they do, but actually things are going really well. And it's okay for that visit just to be part of a check mark or get something else out of it. Ask for a different multidisciplinary team member to come in or use it for some other purpose, whether it's you just want to see a social worker that visit or something like that, because clinically things are going really well and it doesn't necessarily always have to be a medical intervention or something that has to be done. Sometimes it can be, let's just check the box so that you can get your government funding and have a great visit because it's necessary, and get on your way, as opposed to always having something that has to be changed or dealt with. Sometimes they can just be really positive visits too, but giving people with diabetes that confirmation that they can come in and expect to not necessarily always have something scrutinized or changed at every visit.
Yeah, I think when we think about scrutinizing and changing, that's kind of that can be the day-to-day experience of a diabetic. So yes, having moments where it's like, let's appreciate what's working right now and tapping into the positive psychology piece is important. I think when I look at the decision-making piece here, I'm reminded of how often type 1s, myself included, are told like, well, it's a manageable illness. And I think the piece that gets missed there is like, yes, and that's why people are burnt out because there's so many decisions to be made. Like a type 1 has far more decisions to be made in in a day than your average person. So I think just acknowledging that in session or in practice, whatever type of practitioner you are meeting the diabetic, just acknowledging that this responsibility can sometimes lead to fatigue and lead to someone then neglecting their care. And that is, of course, not to be judged, but sometimes, as Michael was pointing out, that can lead to the clinician accidentally being like, what's wrong here? What's going wrong? Instead of being curious about, oh, we can see they're neglecting their numbers. What's happening around there and getting curious about their experience. On the flip side, sometimes the level of responsibility we have can lead to that perfectionistic response, right? Where someone's like overexerting control and having a hard time putting it down and not checking their numbers and not defining their self-worth based on their numbers on their meter. So both of those extremes are on a spectrum, but both need to be met with that unconditional positive regard and also to acknowledge that whether it's perfectionist, neglect, shame, guilt, all of these parts and experiences of the client are actually trying to help the client. Stay with me for a second. Neglect could be trying to help the client by giving them a break. It's not actually helping them though, right? But it's trying. And there might be a part that is like obsessively checking the numbers, right? So much so that they can't live in the moment. But that part might be trying to help them stay in range, but it's not helping, it's hurting them. So acknowledging that all of these bad experiences actually have good intentions is kind of the heart of what I do as a therapist. But when we get specific about numbers and type 1, I'm not looking at pump settings with clients because I'm not a medical expert, but we do talk a lot about this added weight of responsibility and how that can manifest for them.
Thank you
I
so
think
much,
that's a super
Kristen, for
point.
framing it that way. And our next one actually focuses a little bit on that kind of guilt, shame, perfectionism, and how patients deal with that. And we were actually wondering about how do you help patients navigate all the diabetes management options available without pushing one specific device, insulin, or company? What does supportive, patient-centered guidance look like in practice?
Well, I could probably answer that from a technology aspect. When families come in or young adults with type 1 diabetes who are looking for technology options, whether they're at the end of their 4 to 5 years of a previous product or whether they're naive to any technology at all, we always send a family every single option that is available in Ontario covered right now, whether it be by insurance or by the government. And then we tell them to do some research on the options that we send them. And then they come back to us and ask questions. It's really hard when people say, but what one would you use? And what would, which one do you have the majority of patients on? And we can say what some of the choices are based on age, based on athletics, but really what we do is ensure that we've given every single option because it's a 4-year commitment and, they're locked into it. So if we're aware of anything coming down that's in the line for being approved to be released, we let them know. And we have them look and on different websites to see what other people are saying about the technology that they use. And then we answer questions before they decide what their options are.
And I really appreciate what you just said, because this is in essence shared decision making, which is really a framework from which we all should be practicing. But what often happens, and so when you think about the question sort of is pointing to potentially maybe a problem. And the problem is because a lot of the times when shared decision making is used by clinicians, it's like, here are the options, what are your decisions? And what Elena just said is actually really the right way to do shared decision making, which there are 3 stages to it. And the first stage is what we call option talk. Just here are the various options. And then we talk about choice talk. So let's talk about the various options. And that was the key part. So what Elena was just talking about was you give the person the opportunity to reflect and to think about it and to find out information, to ask questions, so that it's almost like you kind of, well, let's see what would happen if you tried this. Let's think about this, the pros and the cons. And then you have decision talk at the end. And as Elena had said, sometimes the person, if they've got a really good relationship with their clinician, they will say, I think I would rather go what you're more comfortable with. So they're actually using the relation. They're not letting the person tell them what to do. By going through that process, when you actually kind of say, well, what do you think, Elena? Like, do you have any thoughts on this? What do you find in this part? And that's actually really important when you get to that stage, because it's not being told what to do. It's where the person is able to capitalize on that relationship. The other aspect to that is that sometimes when you think about various therapies, some clinicians have much, much more experience with some therapies than they have with other therapies. And so in the field of obesity, and individuals who would be seeking or benefit from bariatric surgery, if you look across the country, most bariatric surgery clinics in the country only do a single procedure. There are major centers, so in Toronto and Montreal and some of the major centers, you'll have a lot of surgeons who are doing it, and you'll have multiple surgery strategies. But if you were in Nova Scotia, where I live, there is a sleeve gastrectomy, single procedure. None of the other surgeons do it. And the reason is because you have to do enough surgeries to really be expert at it. And since the population of surgeons is so much lower in my city, there just isn't enough for people to be able to do that. So I think that shared decision making is so important, because it allows the person to really feel that that they're comfortable with the decision. Because at the end of the day, I think when people make a decision, it's really hard to sort of unmake it. And especially when you've got, let's say, a 4-year commitment or something like that.
The other thing that we do also is we ensure that every single person who makes a decision around a technology choice knows that they've got 3 months to change their mind. And we really, really push that our young people who are making these decisions, they exercise their right to change their mind if this technology doesn't meet the needs that they had expected. We encourage them to at least give it a month try before they change to another one, but definitely that they know that they're not tied in for the first 3 months to their decision, and we will support them 100% to switch over to any other product, because we just want the thing that fits into their lives the best way it can to allow them to do what they want to do and live their lives. So if there's one technology they thought it was going to be a certain way and it wasn't, then we 100% help them go through the process of sending back that specific pump or CGM, and we get them a new one, and we will work with every way we can to get a CGM that you like best to work with the pump that you like best and integrate the technology, whether it means a referral to BC for looping, whether it means we have to support you in any other way. We will really, really make sure that it's the right fit for all of the things that you want out of your technology.
Alana, as you're talking, it's so awesome because from a psychological point of view, I would say exactly the same thing with regard to psychological therapies, with regard to strategies to help people. So we're working with somebody and you're trying to help them change their behavior, you're trying to help them manage their emotions, maybe you're working on relationships. And I think it would be exactly the same point that Alana is saying. Don't evaluate how effective it is. Don't evaluate how committed we want to stay to the intervention until you've had enough time. So I will say to someone, I'll say, if you're going to try a new behavior, don't evaluate it until you've done it at least 30 times. And so, and the process that Alana just described with regard to making sure that so it's kind of like this, like, does the technology and you fit together? Does the technique and you fit together? And I think if we take that attitude, it becomes a lot easier. And also it invites the person's voice, right? We really need to help people with diabetes feel comfortable sharing their concerns, because it can be challenging if a doctor prescribes a treatment and then the patient doesn't like the treatment. It's a very difficult thing for the patient to say, "Doctor, I don't like your treatment." Because think about it, the patient is in a situation where they're vulnerable. They often have a high degree of respect and value the caring that the clinician is providing. So it's very easy. And that's why I think it's so important for us to recognize letting people try things on, letting people become comfortable. And above all, it's that sort of continuing voice of the person with the disease.
Yeah, I think going into appointments or sessions with no agenda as the clinician is extremely important, which is what you guys have been saying, that, we don't want to be allowing or leading the client to feel pressured in any way to make a decision, even if we might have a personal preference. I remember one of the first things I learned in school to become a therapist is avoid projecting personal biases onto your clients, right? So I might really love my pump, but if the client says to me, what do you think? It does have to go back to, okay, how can I share my experience without also then like shaming other options? So I might share what I love about my Omnipod, and then end very strongly with, but I've also never had the pump you have. So I have no idea what that's like. And maybe I'd like that even more, right? And maybe you would hate the one I have. So just to really come back to subjectivity. And I think that building on what Michael was saying there, them asking shows that level of trust in the relationship. And that's such a sacred moment that you really want to make sure you're not taking advantage of.
Doctor, what would you use is probably one of the most commonly said phrases in medicine, not just for diabetes, but I think it just shows, the level of respect that a lot of patients have for the opinion of their provider. And within the realm of diabetes, I think it's very appropriate because diabetes technology is changing extremely fast, and especially over the last 10 years, there's just really been a surge in things that are making patients' lives a lot easier, and that I think just the nature of this question is such that we're considering all these pump options, which is actually a privilege. Like we have so many options available for patients that regardless of their lifestyle or like what their preferences are, there generally is an option for those people. So I think everything that's been said before, I totally agree with. One thing I wanted to also add is that I think when physicians are asked, like, like what would you do? I think part of it is also like they might have their own experiences with different pumps, as has been said. But I think using objective statements, these are things that patients generally enjoy, and like patients really enjoy the aspect of maybe having a wireless pump, but at the same time one commonly reported thing is maybe it falls off, or like phrasing it a bit objectively so that they feel that it's not really from a place of bias but rather from like just understanding that physicians patient population pretty well. The other thing I'll add, I guess, from a personal perspective is like I've transitioned from like injections when I first started, so I've tried quite a few things. And one thing I always appreciated from my provider was never feeling rushed to hop on something. And I think that just came from the fact that for the many first few years of my diagnosis, I was extremely active, and disconnecting and connecting with my pump, playing things like soccer and basketball was just not really something that I wanted to do. And now I still play a lot of sports, and I found a lot of comfort with the wireless. And that's just something that fits my lifestyle, but someone else might have their own, way of doing things. So putting the patient at the center of their management and just giving them all the options helps them feel empowered to make a decision that will serve them best.
Thank you for that. Like, look, like reflecting back on when I was having conversations with my healthcare team in peds about, using a pump, I remember like the way that I was processing the information. I was like, what do you mean I have to go into a hospital every 3 days to change my pump or to change my site? Like, that's how I, as like an 8-year-old, interpreted like going on a pump. So I was happy to also have my parents' support in just sticking to MDI for the time being, because I don't know, either refusing to listen or I was just confused. But then also with kind of that same healthcare team, it was interesting for me as a patient to have to kind of walk them through why a pump was not ideal for me at that time because of the visibility that came with it. And especially coming from a Punjabi background, I'm the only one with type 1 in my community. Like that meant more eyes on me and not necessarily more care for me. And so I remember having someone just be like, well, what do you mean? Like, you can't show off your pump? What do you mean people are going to give you a hard time about it? And it just added to like this internalized like guilt and kind of shame I felt around diabetes. And then also it added more stress when I was at like family functions and like people were watching what I was eating or what I was picking up. And so with that being said, we know that there are so many factors that affect blood sugar levels like day to day. So stress, sleep, hormones, activity, illness, and so on. What advice would you give to future physicians to think about when it comes to variability and avoiding oversimplifying insulin decisions?
I think one of the things that has been so valuable, and that I think we can feel comfortable with advancing in diabetes, is the concept of readiness to change. And in other words, when it comes to any kind of behavior, so we're talking about, Rav, your own personal life, are you going to go on a pump? Are you going to stay on MDI? And a really valuable way of thinking about this, rather than prior to the concept of readiness, we used to think, well, if you're not ready for it, then come back when you are. Like we used to think as clinicians, there's nothing, here's what we'd like you to do. We make a recommendation. You're not ready to do it. Okay, fine. Come back when you're ready. And we've realized over time how damaging that has been to the person and how disrespectful it has been to the person, because we're not taking into consideration, why aren't you ready? So there's a concept that we've really been successful at, And it can be quite simple. And I use the traffic light metaphor. So, you could look at Rav, maybe you're 10 years old, and we can say, okay, 10-year-old Rav, how ready is Rav to use a pump? And maybe in that situation, she's red light, stop. Perfect. Now, why are you red light? And all of a sudden, we can understand there are cultural reasons, there may be developmental reasons, there may be financial reasons, and actually good reasons why people are either green light go, they want to just go right, full bore, yellow light, they're kind of, I don't know whether to do it or not do it. I'm not saying yes, but I'm not saying no, or no, I'm not ready for that. And I think one of the things that we've really got some success on in Canada in diabetes is providers recognizing that that's completely legit. So we don't get stressed when the person isn't ready. And because you know how that goes, right? And you may have actually experienced this with clinicians where, they've made a recommendation and you're not really excited about it, and then try to push the recommendation on you rather than understanding, why isn't it the option for you? And when you do that, then you all of a sudden you would understand that, all eyes are on you. Why can't you show your pump? Well, you've got very, very good reasons, right? So you could imagine, after that conversation, Rav, if someone were to say, not be judgmental, be curious, then you would leave the clinic saying, of course, don't show your pump. Because for you, hiding your pump isn't avoiding anything. It's actually an effective coping strategy given the circumstance. And it's that nuance. It's that we have generic knowledge. I always like to say to my colleagues and remind myself that we are generic, so as a psychologist, I can do all kinds of things, but we have to personalize it. So it's like you have to fit it, make it fit yourself. And the only way to do that is for the voice of the person to be there, for the voice of the person to guide. And so I just wanted to pick up on that kind of concept of readiness because I thought it was so valuable what you were saying and what might be potentially kind of a stressful situation. Oh, we've got to, and without that sort of acceptance of readiness, you could imagine that sometimes language like the person's non-compliant, oh, they're in denial, oh, they don't care about their disease. This is language that is not uncommon when you take that, kind of transactional approach to diabetes, where we know that it has to be a relational approach.
I think this really highlights how change at a systems level is so important. And this relates to what you said, Ethan. We can't be too hard on the physicians because it comes down to, well, what are they being taught or what are they not being taught? And what you're describing there, Michael, is a lot of motivational interviewing, it's called, right? So how are we giving the clients permission to share more and to learn more without putting our own agenda onto them? For anyone who hasn't heard of him or read this book, Dr. Robert C. Smith has a book called Has Medicine Lost Its Mind? He's wonderful, super, super insightful, and he talks about how literally along the way, Western medicine forgot and kind of dismissed the concept of mind-body fusion, that there's no separation. And that is what has led to a lot of the course correcting that needs to be done now, where we're coming back to asking clients, like, as a physician, so how does that make you feel? And what's happening here? What's really going on beneath the surface? And I really like how he highlights this doesn't mean that the family physician or the endo is becoming a therapist. It's more that they're using therapeutic techniques at a very, very, very basic level, which comes down to just being curious and giving them the floor. And it doesn't even take longer to do the meeting. And he's proven this through research. So his book is super interesting. I would recommend it to anyone looking to get into the medical field in general, but especially with type 1 diabetes.
Thanks, Kirsten. I wrote down the name of that book as you were talking, so I'm definitely looking forward to reading that. When I first got this question from Rav, I took it in more of a literal clinical context kind of way and thought about what future clinicians, like what clinic visits might eventually kind of changed to, and some of the topics maybe differently from 20 years ago, where we would see a family or an individual and try to see how they could fit their life into the diabetes regimen. Whereas now I feel primarily we are just trying to make diabetes fit in a way that the person can live their life to the fullest at all times, and diabetes not interfere as much as humanly possible. And some of the things the metrics that we're looking at clinically now are so different from before. Things like measuring quality of life, sleep, and the importance of ensuring that a night's sleep is part of a clinical visit. What kinds of things can we put into place to enhance sleep? If you're having lows in the night, if your technology is going off, what can we do with settings and help out as much as possible to promote the absolute best night's sleep, so that the days are so much more able to be functional. And so just knowing that our diabetes clinic visits are morphing into more different areas of focus than we would have traditionally been in the past. And I can see clinicians of the future, having a baseline quality of life survey, and then using different measures or conversations or therapeutic interventions to continue to meet the patients where they're at, talk to people, and just focus on different things than maybe past clinicians have been taught, and hopefully do a much better job in that therapeutic relationship between people with type 1 diabetes and the clinicians that see them. That is my hope.
Just touching on things that you're sharing there, Alana, around new research and new education on all of the things that intersect and influence blood sugar, things that I wish I knew when I was younger, and whether or not the research was out, I'm not sure actually. I was 6, but I learned these things only like a year ago. I learned about the interaction between protein and fat, and dosing for protein that metabolizes in the liver, and that's glycogenesis. And maybe all this is jargon. It was jargon to me, and I'm 28. So looking at the intersectionality between all of those factors, sleep, hydration, your menstrual cycle if you're a woman, looking at all of these different factors that are going to influence what your sugar is that day. Although it can feel overwhelming without having, the information to back it, slowing down and learning about this with a diabetes health coach, with your endocrinologist, doing your own research on it. I think anyone coming into this field ready to support new type 1 diabetics, giving them this information off the bat instead of all you have to do is count carbs and have some sugar before you work out. Those are kind of the two things I was operating on for most of my life. So if there's a way to understand more of the nuances and kind of impart that onto new type 1s, or type 1s at any age, really, I think it can be absolutely life-changing.
I have a follow-up question for you, Kirsten. So when you are like reading about all of these kind of like, like how proteins and fats and how are, having like a good plate, using the plate method and how that's all like beneficial, how do you deal with, or how would you suggest dealing with any guilt someone might feel for not knowing that sooner?
Mm. Yeah, I think that's such a good question, and it's something I had to process as well. There was some shame around getting coaching myself, so I was engaged in a diabetes coaching practice for 3 months with a one-to-one facilitator over this past summer. And there was a lot of resistance leading up to that, because there can be embarrassment around, like, I've had this for most of my life. Shouldn't I know these things? I think the thing that broke down my barriers was being part of more T1D communities. So if anyone has heard of Risley Health, they're based in the States. They're who I did my coaching with. I connected with them online. I actually was interviewed on one of their podcasts, and then when I got talking with the woman who interviewed me, I thought, well, maybe I should do some coaching. Like maybe I should be involved in that, receive some coaching rather. And so I think just being part of community can help humanize it. Operating by yourself, it's easy to be like, yeah, I got this, and no one can tell that you don't when you don't. So just being more human, being more connected, can help someone kind of soften. And I hope to do that, as a therapist with my clients, to just normalize that, when they're having a shitty blood sugar day, that yeah, like I had a scream cry session in my car because I had popcorn the other week, and like that happens. And also empowering, here's how it can look different, and here's what I've learned, and here's what I'd like you to learn.
This is such an important issue to talk about. Because humans by nature are social beings. And so we have a social survival instinct, just as we have a physical survival instinct. And that's a good thing, obviously. But what it does mean is that we engage in social comparison. And so what we just witnessed was a discussion that involved this social comparison. So Kirsten was talking about a phenomena, and it was like, oh, maybe I should know about that. Notice that, Rav, you had that kind of reaction. And that's what humans do. And so it's so important, if you join the diabetes community as a professional, to really always take the perspective of it's got to fit you. So if that, at that point in time, that was the right thing for Kirsten to do. And so we need to hold on to the fact that, and that's again where the readiness concept can become really valuable. Is that something that you're ready for? And also, just what's your personality? Do you like numbers? Do you not like numbers? Do you want details? Do you don't like details? Do you want to just get into sort of, are you kind of more of a rhythm type of person? Are you a very structured person? So, and again, as has already been said, we're not talking about working with complex traumas. We're not talking about dealing with early psychosis. We're not talking about psychopathologies for which the mental health skills require a lot of professional training. So there are areas where you need to be a qualified psychotherapist, a social worker, a psychologist, a psychiatrist, and all that's well and good. What we're talking about is actually, again, it's just bringing the mind into medicine, isn't it, Kirsten? And so I think it's really very much around recognizing that and really trying to promote this, trying to correct that social comparison. You be you, I be I, right? And so it's all trying to manage that. And again, it's so important because it is a natural thing to do. And it does require a little bit of support because we need to try to take the sting out of that. And so, that's a real cool thing that you're reporting, but not everybody would find it helpful to them. And what we don't want is to get that kind of, guilt response. And what I try to also emphasize is that when you're trying to understand diabetes, also really try to make sure that we give people permission to tell us what their struggles are. Because many people feel like they don't want to let their clinician down or they expect it. So for instance, one of the best kept secrets in type 1 diabetes management is about, some surveys. This was a study done in Scotland. 70% of the patients missed 30% of their doses in a 6-week period of time. In other words, it's very normal for people to not take all their insulin. And yet, this is not common conversation. I think we all should be saying, look, you know what? It's normal for people to not, this happens, right? The World Health Organization has recognized that over half of medications for chronic diseases aren't taken. So and you just saw this last couple of months, we heard about, these blockbuster GLP-1s, the Ozempics and Wegovys and Zepbounds and tirzepatides for weight management. Now the non-adherence, guess what happens? 60% of people stop taking these drugs after a year, and not just because of finance. So, it's so important to normalize and try to really help people to reduce that sort of social comparison. So we don't want this to be a guilt-ridden experience. We need to help people recognize that where they are is where they are, and our job is to meet you where you are. And this is something that from a psychology perspective, I can tell you, if there's a pathway that you're interested in taking, the chances that you can get there are super high as long as you take an evidence-based guided approach, which is about empowering people. And so I think that these conversations that you're raising when you talked about that, Kristen, was so interesting.
Thanks, Michael. I just want to add to that as well. When you say, giving people space to not be okay, and that's kind of that's the therapeutic model. And I just want to name right now as well that we're hearing from like so many different clinicians. And I think from the therapeutic standpoint, we almost have an advantage compared to the endo or the nurse, who is, or even the health coach, right? Who, when they're coming in, the diabetic might be, okay, like I know my numbers are going to be up on the screen. Like I know that's going to be happening. There might be anxiety about that already before you even arrive. You can show up to a therapy session. You don't have to tell me your blood sugar if you don't want to. I mean, you can, and we'll navigate that for sure, and keep that in mind. And it can even help deepen the session. But just to name that, such different experiences, and the way that a therapist hopefully is creating space for the client is already, like this is the space to cry about it if you want to. In a medical office, it's not going to feel that way necessarily unless we are back to like systems level changes, acknowledging that this might be a really tough day for the client. What if the patient is coming in and their blood sugar is 15 and they're about to review all their numbers? Like that is an important factor to keep in mind before we even go in and review them.
Absolutely. Thank you, everyone, for such amazing answers on that. At this time, are there any questions from the chat?
I have a question. She says, thank you so much for sharing all your knowledge and expertise. Do you have any practical tips you use in the clinical setting to balance addressing both the psychological and more physiological, biological aspects of diabetes in the time constraints of appointments?
Perhaps I can just make a comment about time, because this is actually critical. So I'm a psychologist, and I try to promote the integration of the mental health signal into the physical signal in diabetes. And almost to a person, my colleagues will say, all well and good, Michael, but I don't have time to do this. And the time in the clinician's mind is such a profound thing. One of the things that, and Kristen has referred to this already, it's really how you use the time. And I think if we think about how we can really structure the time so that we negotiate. And so, one of the things that you would do is negotiate how you want to use the time that you have. And therefore you can balance that. And that time can be, thanks for coming back in. We've got about 30 minutes for this session, 20 minutes for this session, 40 minutes, whatever it would be. This is the time that was sort of allotted for the appointment. And, how do you want to use the time? And then you just balance. And I would say that this is where we really need the voice of the person, because it would be like, okay, we can talk about how diabetes is affecting your life. And then also we can talk about how do you manage your diabetes using the therapies. And we can put those on the table, and it's a relationship. And like all relationships, each person has a voice. And so and I think it can go really well when the patient might say, I'm struggling. I'm really struggling. I had some events that were happening and I'm really feeling really stressed. And so then, you might think, okay, let's, give you some space, give you some time to talk, give you some bit of time to vent. And then can we save a few minutes of the session to deal with X, Y, or Z? And what we find is that people are really able to co-create an agenda in which so how I try to say it is that it's not finding the time you think you need, it's using the time you have. And the one thing we do know about time, I will make a critical comment about clinical medicine, is that the evidence shows that a patient requires about 90 seconds to complete a full thought. And clinicians interrupt between 16 and 22 seconds after the person has started to talk. And so the time perspective shift that I try to say to my colleagues is, I'm just asking you to be quiet for 90 seconds. just let the person speak for 90 seconds before you kind of bring it. So I think time is a really important issue to talk about. And I think it's a little bit of a, when I see it, I interpret that when the clinician says, I don't have time to do that, I interpret that as the clinician is stressed and perhaps feels that they're a little bit out of their comfort zone. And so I try to take a perspective of supporting them so that they can try to learn to use time effectively. And we find that this actually works super well.
I'm just going to drop in the chat here Robert's patient-centered interviewing model, because that is very much what you're speaking to, Michael, around asking the questions, giving them space, not interrupting, some very, very important relationship building techniques that do not take any longer and in some case actually help the meetings go faster. So that was something he really highlighted in conversations I've had with him around this this being one of the major things he hears from physicians. He is one himself that, we don't have time. And so this is a very simplified way to kind of package it up and make it digestible to a physician. It doesn't mean doing a psychology degree. It just means, as you're saying, Michael, maximizing the time you have with relationship building.
And one thing I'll jump in and say is that what I've learned is a lot of people, it takes a lot of courage to even show up for an appointment to begin with. And sometimes we just kind of assume that people are kind of ready to just go to their appointments, and we'll go to them on schedule and we'll book the follow-up. But I've learned like a lot of people, just kind of getting them in the office is the hardest part, and that they keep kind of rescheduling. And it's easy for these people to kind of get lost in the shuffle, especially when things are very busy for clinicians. So I think I agree with like the element of just letting the patient kind of guide the encounter, not kind of forcing an agenda. I think I really like what Kristen said earlier about like, not having a full agenda. I know that's not always feasible. I think many clinicians would tell you they would have a very hard time in clinic if none of the appointments had an agenda, but totally understand what you're saying in terms of not forcing it upon them, because there are certain things that have to be talked about. So those are for sure like non-negotiables to discuss, but the encounter itself doesn't have to feel so rigid, and not give patients the flexibility to talk about, things that they've come to the appointment wanting to talk about.
I just like to jump in here when you talk about patients not showing up, because I think, Ethan, you're absolutely right. And these, we call them no-shows, and it's important. And one of the things that I really try to emphasize with no-shows is that no-shows, in my opinion, are a reflection of us being judgmental. Just imagine, right? What is the chance that the person completely forgot about the appointment? A no-show is usually a case where the person is feeling like they're not wanting to come in for a reason. And usually it's because they anticipate judgment. And so it's so important for us to be mindful of that. When you look at your no-shows, think about the relationship you have with those people. And why don't they feel comfortable? Because they could have called you up a day before and said, I don't think I want to come in. I'm going to cancel my appointment. I'm going to reschedule my appointment. They don't. They just don't show up. And so they must have had some sort of desire to show up and then got frozen. And that's on us. And so many clinics look at no-shows and think, oh, those people, they're so disrespectful. They're wasting our time. Why didn't they come in? We get frustrated at them. I try to reframe that to my colleagues and say, if the people aren't showing, why aren't we making it welcoming enough for them to show up? So I think no-shows are incredibly important. And actually, one of my Ph.D. students actually wanted to work on her Ph.D. dissertation on this issue. And so we tried to identify people who were no-shows and get them to come in for some qualitative interviews. So as Alana is talking about, kind of getting these people involved in the research process. And we couldn't do it. They basically they didn't trust us enough to actually kind of come in to do that. So I just want to flag that issue as you go forward, to really be thinking about when a person who accepts an appointment doesn't show up for it, it's probably because we're doing something wrong.
I totally agree with all of the points discussed here. And one of the techniques that we use in our clinical space is at every clinic visit, we start the visit with, do you have any questions to start before we start the clinic visit? Because sometimes there's an agenda of things that we are obligated to collect or do in a routine visit. So making sure that at the onset, we are answering any burning questions so that they don't spend the whole time there worried about those things and kind of then at the very end feel like they're rushed or didn't get that part of the visit completed. So that's kind of one of the practice things that we do just to hopefully capture that at the very beginning and help them set the tone for the visit.
Okay, and as that being our last question for tonight, I just wanted to check if there are any last words that you wanted to say about our conversation tonight.
If you're thinking about your careers, you're thinking about where you're going to go, you're thinking about diabetes, I've been involved in this field for just over 40 years. And it's an incredibly rewarding career to work in the field of diabetes and to learn from people living with diabetes. And the interprofessional relationships, honestly, the respect that I have felt as a psychologist in diabetes from my colleagues, the respect that I have for my endocrinology colleagues, my dietitian, my diabetes nurse educators, the pharmacists. I mean, it's an incredibly functional team. I don't think we're doing a perfect job by any means, but I do believe that we have our hearts in the right place. I believe that we do the desire to listen, I'm saying this because there are other kinds of clinical work that we can do where there's tension in teams, and it can be a stressful experience. And I know a number of psychology. It's difficult to hire psychologists in hospitals in Canada because psychologists have tended to go into private practices because they find it a bit easier professionally. But I love working in diabetes, and I learned so much from my colleagues. And so if you in terms of career satisfaction, I just think my life would be very different in a negative way if I hadn't had the privilege of being connected to working in diabetes. So I just wanted to make sure I said that before the time went out.
And Michael, I 100% agree that this profession and getting to work with the families and the young adults with type 1 diabetes, it is such a privilege to be able to just in any way part or like that we can be able to help. They're so resilient, they're so strong, and clinically to have a whole team and a network of people to work with, to like with the same common goal, it is the most satisfying career, and I can't imagine loving any job as much as I love this job. So it's a privilege and a pleasure. And even seeing some of my ex-patients on this Diabetes Hope call tonight, it is just a joy. I get excited every time I get to see them again or reach out or bump into somebody. So definitely a very rewarding career and profession.
I think being able to work with clients who are type 1 diabetic as a diabetic myself has really forced me in a healthy way to look at my relationship with type 1 diabetes. So kind of circling back to the question you had asked me a little bit ago, Rav, about like guilt and shame and how to kind of move past that and learn new things. When we see in our clients or patients things that reflect back to us. Clients and patients will often not directly but indirectly point out our own blind spots. And so I'm very grateful to my clients for, whether they know it or not, helping me, they definitely don't know it, helping me look at my management more closely, which then leads to me deepening their care. So that's huge. It just comes back to community.
I'll end it off by saying I'm very early in my career. I have the privilege of having learned from this panel from a lot of people who are a lot further in their professional journeys. But one thing I guess I'll say is that from a patient perspective, like I think it's so important to have conversations like these, to just hear from people who, take the time to really get to know their patients, can understand some of the things about living with diabetes themselves and use that to kind of guide care in a way that's, empathetic and patient-centered. For me, like I have a pretty long road ahead of me and, there's so much like, I guess, uncertainty within the field of medicine of where things will go. And so we can only really take things, day by day, especially in such an evolving field like diabetes. But I think what will always go a long way, like irrespective of technology and all the things that are advancing, is just how we make patients feel. And I think one of the common things that we talked about today are just strategies that hopefully people leaving the session can feel that they've got a good grasp on of how to put patients first, especially when providing care to them. So I think, as Michael said, and everyone else kind of agreed with that, this is a very rewarding field to be in. And I know I've experienced that on the receiving end. But in the future, like if the opportunity is there, I'd love to also pay it forward.
And just say to you, Ethan, the people living with type 1 diabetes who work in diabetes, we love you guys. I mean, we find it incredibly valuable to have the lived experience as part of the sort of collaborative teams. It's a real nice fit. So if that's an interest that you have, Ethan, you'll be very welcome into the field.
Okay, so that was great. Everyone, let's give a big thank you to all of our speakers today for sharing their insights. And thank you to all the attendees for joining in on this, just wonderful conversation.
And I just wanted to say another thank you to everyone for being here tonight. I wanted to thank all of our attendees for being here, as well as all of our speakers. I just wanted to say it is so clear how passionate all of you are about your careers from hearing you speak, and it's so inspiring for me to listen to all that, and it's been a pleasure being here with you tonight. I also wanted to highlight a few things. In case you wanted to take a peek at our guide to adult care, we will also post a link in the chat for you to view it. And we're going to be adding a link for an article from Diabetes Care Community written by Dr. Vallis about tackling stigma in school environments, featuring quotes from community members. It's a really great read, so I really suggest looking at that. And all the other links should be in the chat as well. Just wanted to say one last big thank you to our attendees for joining and adding to the conversation tonight. We appreciate your time, and we'll catch you at the next webinar.
Bye, everyone.
Thank you for the invitation. Bye, everyone.
Take care.
Thank you so much
For being here.